This is the continuation of Respiratory Physiology. It's Unit 6B. An important aspect of being able to understand what's happening when a person breathes in is that a negative pressure is generated. The atmospheric pressure of 760, I would remind you, is ignored. Therefore, a pressure of 0 is equal to 760, right? Anything below 760 is a minus. So here you have 756 being equivalent to a minus 4. Well, what's happening when a person is not breathing at all, there's no flow of air in and out. The mouth is open, the airways are open, but there's no flow of air in or out. That indicates that the intrapulmonary pressure is equal to atmospheric, and therefore there is no flow at all, because there's no pressure gradient. An important aspect to understand is that the lungs, of course, are surrounded by the visceral pleura, the visceral pleural membrane, and the wall of the lungs, the wall of the thoracic cavity, is surrounded with the parietal pleural membrane, so the parietal pleura. The two membranes have a space between them that's filled with fluid. When a person breathes in, what they're doing is they're contracting their diaphragm. And the diaphragm is contractile muscle tissue. It is voluntary contractile muscle tissue. And when it contracts, it has to descend and move to this new position shown here, across here, because it's now shorter, so the only way it can actually contract is if it descends down. Plus, the external intercostal muscles, when they contract, they'll raise the rib cage. And so overall, the volume of the thoracic cavity enlarges. With that increase in volume, you get the pressure decreasing. So the pressure will drop, and as a result, the lungs always stay in contact with the thoracic wall and are surrounded by those two membranes. The increasing volume of the thoracic cage draws the lungs outward because the pressure, the intrapleural pressure drops, and it is always lower, in fact, than the intrapulmonary pressure, and so the lungs are always pushed up by that higher intrapulmonary pressure up against the thoracic wall. And the pressure inside here in the two lungs drops down below atmospheric pressure, and so the air rushes in. Now the opposite effect will happen when the person breathes out. They passively relax the muscles, the diaphragm and the external intercostal muscles, and the diaphragm pops up and the rib cage drops down, and the pressure inside the intrapleural space is still below the intrapulmonary, but is increased. Pressure rises in the intrapulmonary space, and it rises enough such that it is greater than atmospheric pressure and the air flows outwards. Now, in terms of the different pressures in the respiratory system, the pressure in the intrapleural space is called the intrapleural pressure, and it is abbreviated P subscript IP. The intraalveolar or intrapulmonary pressure is P subscript PUL, and the transpulmonary pressure, the difference between the two, is shown here. Transpulmonary pressure is the thing that keeps the airways open. The lungs would collapse if the intrapleural pressure equaled the intrapulmonary pressure, or if the intrapleural pressure equaled the intrapulmonary pressure, the lungs would collapse. There would be nothing pushing the lungs up against the wall of the thoracic cage, of the thoracic cavity. The key physical factors or variables that influence ventilation, the main one is in fact resistance to flow. The thing that resistance does is it has quite a large effect on the ability of air to flow. It is an inverse relationship. The driving force, of course, is the pressure gradient, the difference in pressure from one side to the other. So flow is equal to, in fact, delta P, the pressure gradient, delta P, divided by resistance. The amount of gas that can flow into or out of the alveoli, as you can see, is directly proportional to the pressure gradient and inversely proportional to resistance to flow. And the key factor is the diameter, the total cross-sectional area, or rather diameter of the bronchi, and the greatest resistance to flow typically is in the medium-sized bronchi within the pulmonary system or respiratory system. Here you see this relationship, the medium-sized bronchi showing here the highest level of resistance. We're looking at resistance versus the airway generation of branching. Remember, there are 23 branchings of each of the airways. The first branching would be the two primary bronchi, and you go, and those again branch and split into 23 times. At this stage here, around this generation of bronchioles, remember a bronchiole is anything with a diameter of less than 1 millimeter. So around here you have the division line typically between the terminal bronchioles and the alveolar bronchioles and alveolar ducts. So this is on this side, here on this side, this would be the conducting zone, and here would be the respiratory zone. So the main location in terms of causing resistance to flow is at the level of the medium-sized, between 5 and 10 airway generations or branching. Airway resistance, when it increases, breathing movements become much more strenuous. The person has to make much more effort to inhale and exhale. If the bronchioles are severely constricted, if you have bronchoconstriction, or if they're obstructed by whatever, well, it could be many things, but the most common thing that they get obstructed by is mucus. But with inflammation, you have fluid and mucus and inflammatory cells. But anyhow, any of those can obstruct or block. That will dramatically increase airway resistance. Or if they are constricted, they're narrowed, then you'll have increasing airway resistance. This can actually get so bad that it's life-threatening, and the person cannot adequately ventilate their lungs. In a very acute asthma attack, can actually prevent adequate ventilation. Now, one of the neurotransmitters of the autonomic nervous system, is of the sympathetic branch of the autonomic nervous system. Epinephrine will trigger a dilation of bronchioles and therefore reduce airway resistance. And so people who use inhalers that contain a bronchodilator, it's not epinephrine, but it has epinephrine-like effects, and it will, when they inhale, it causes a relaxation of the smooth muscle that's wrapped around the bronchioles, and so you get a relaxation. That's why their heart rate often rises, because they're getting that sympathetic, mimicking sympathetic activation. The key things, or the key factors that are acting to pull the lungs away from the thoracic wall and are promoting lung collapse are the elasticity of the lung tissue. They tend to assume a smallest size unless maintained by pressure differences and inhalation. They'll tend towards getting to a smaller size due to the elastic fibers wrapped around the exterior of the alveoli, and also the surface tension of the alveolar fluid within the inner space of the alveolus also tends to pull them to a smaller size. That's opposed by the elasticity of the chest wall, which helps to pull the thorax outwards in the large lungs, and also that pressure difference between the intrapulmonary and intrapleural pressures. Remember, the intrapleural pressure is always lower than the intrapulmonary. That idea of surface tension of water is simply the attraction of liquid molecules, water molecules, to one another at a liquid gas interface. It is due really to hydrogen bonding. Hydrogen bonds are not particularly strong, but when there are so many of them, they do have some significant effect. And the liquid on the inner surface of the alveolar epithelium will tend to want to draw them close and reduce them to the smallest possible size. The key factor that prevents that is the secretion of the detergent-like molecule surfactant, which helps to reduce surface tension and keep the alveoli from collapsing. Now, in respiratory physiology, physiologists always like to talk about, instead of elasticity or recoil of the tissue, they prefer to present it or discuss it in terms of compliance. Compliance is the ease with which the lungs can be expanded. So it's essentially the inverse of elastic recoil. Ease of expansion as opposed to collapsing force. So the relative change in lung volume that will occur with a given change in pressure is the compliance. And the key factors that determine compliance are the distensibility of the lung tissue and the surrounding thoracic cage, and the surface tension in the alveolus and the alveoli themselves. When you look at lung compliance, you should understand that the more change in lung volume that occurs with a given change in transpulmonary pressure, the higher the compliance. If there's less of a change in lung volume, then the lungs are less compliant. Compliance typically actually is reduced at the higher and lower ends of the possible extreme ends of the possible overall range of lung volumes that can occur. As the lungs expand out, compliance gets reduced, and as they get emptier and collapsed, or it gets smaller because they're emptying out, the compliance gets reduced at that smaller end of volume also. So it's not a feature that is continuous and constant as the lungs fill and empty with air. It is reduced at the higher and lower ends of the possible range of lung volumes. There are factors that diminish lung compliance, and these are abnormal factors, scar tissue, or buildup of connective tissue, fibrosis will reduce the natural resilience of the lungs and reduce their ability to expand with a given pressure change. So that reduces compliance. Blocking of the smaller respiratory passageways with mucus, the smallest bronchioles with mucus or fluid also will reduce compliance. If there's a reduction in production of surfactant, if surfactant is reduced, also that will cause a reduction in compliance. If the thoracic cage, the wall, the actual wall of the thorax, the cartilage associated with the rib cage becomes stiffer, has reduced flexibility, then you will get a reduction in compliance. Or if there's any decreased ability of it to expand out for whatever reason, here's some possible reasons, then again that would reduce compliance. The flexibility would be caused by ossification of costal cartilage. Costal cartilage is the cartilage that joins the ends of the ribs to the sternum, and ossification is calcification essentially of that and making it stiffer. So all of these can diminish lung compliance. There are also factors that can increase lung compliance, and this is normal. The production of surfactant significantly increases lung compliance. The lungs become much easier to expand, and you can try for yourself if you take a very thin plastic bag and put a little bit of water into it and collapse it completely so that there's no air in it, just that small amount of water, and then try to blow it up, you'll see that there is some difficulty in blowing it up. But if you add just a small drop of detergent to the water inside the bag and spread it around and then try, it takes much less pressure to pop that plastic bag open. That's because the small amount of detergent in the water is mimicking the same effect as surfactant. That would be a normal mechanism for increasing lung compliance. There are also abnormal ones that increase lung compliance. Remember, compliance has a sweet zone. It's not good if lung compliance is too low or if lung compliance is too high. A major disease process that will increase lung compliance, ease of expansion, is called emphysema. In emphysema, what's happening is that there is an actual loss of lung tissue. It's being destroyed. You're losing quite a bit of the alveolar tissue, and along with that, you'll have loss of the elastic fibers around the alveoli that were lost. And so with that loss, you have a relatively much easier inflation of the lungs. The problem is when people with emphysema want to breathe out. Well, of course, there is a major problem that they've lost significant surface area, functional surface area for gas exchange. But the other thing is that they have quite a bit of difficulty exhaling because there's, compliance is ease of expansion. Compliance has gone up, but with the loss of the elastic tissue, it doesn't collapse downwards when you're trying to breathe outwards. So you don't have this easy a time of breathing out. Well, This again shows the respiratory volumes that you hopefully are familiar with now using spirometry. There's the tidal volume at rest, breathing in and out, shown by these, up and down volume changes. Upwards, of course, is the default for, in these drawings, for, in this case, this type of drawing of volume over time. Upwards is inhalation and downwards is exhalation. Remember that in the flow volume loop that you looked at in the lab, or we'll look at in the lab, that's not necessarily true, that up is inhalation and down is exhalation. But for these kind of graphs, volume versus time, that's the default. So you have tidal volume. Tidal volume in male or female typically is about 500 mLs, average size adults. You have quite a large, this by the way is a male record, you have quite a large inspiratory, do it in another color, inspiratory reserve volume, and that's shown in that portion of the graph, and you have the expiratory reserve volume shown here in the graph here. So tidal volume, IRV, ERV, the sum total, and TV, tidal volume, the sum total of that is the vital capacity. When you look at the difference between male and female, you see tidal volume is the same, but males typically have a much larger inspiratory and expiratory reserve volumes, so that the even though the tidal volume is the same, the IRV and ERV adds another 4.3 liters here, as opposed to an average of 2.6 liters. So on average, that would be 1.7 liters more in a male than an average female, which is a significant difference. So the chest is larger in terms of the space, in the thoracic cavity space in the male, and an average male is overall larger and so has a bigger IRV and ERV. Again, same thing what I discussed earlier. One thing I do want to tell you and mention again is that the air volume left in the lungs after you've expired as much as you possibly can, once you get down to expiratory reserve volume, that below that is the residual volume, the volume of air that cannot be expelled from the lungs after trying to expel as much as you can, and that amount remains unchanged regardless of whatever volume you started breathing out. If you started breathing out as much as you possibly could at the top of a tidal breath, then you still get down to this level and you'd still have a fixed residual volume. That's the volume of air left in the alveolar space that is available. That volume of air is available for gas exchange. And it's not insignificant. In a male, if we have a vital capacity here of 4.8, 3.1 plus 500 and 1.2, that's 4.3, 4.8 liters. The residual volume is 1200, 1.2 liters, so that's 20% of the total. The total is 4.8 plus 1.2 is 6. 12 is 20% of 6, yeah. So it's a significant amount of volume that's still there after you breathe out. You know, the alveoli do not completely collapse when you breathe out. There's still some, there's still some air held in there, and it's not an insignificant amount. So we've covered each of the key volumes and vital capacity. I want to, each of these volumes and the vital capacity, I want to also show you that there's these other capacities besides vital capacity. For some measurements, by the way, that vital capacity is, we measure forced vital capacity, which is when you're trying to get it out as quickly as possible. It's no different from vital capacity, but forced vital capacity is when you
really exert as much as you possibly can. And that's the kind of thing that we looked at in the lab, in lab 7, where the person is trying to expel the air as much as they possibly can to see how much can be expelled or exhaled in the first second. That was FEV1. So let's just talk a little bit about dead space. Please, I added this note here, down here. Do not confuse residual volume with dead space. Dead space does not take part in gas exchange. Whatever volume you have in those areas of your respiratory system that cannot participate in gas exchange, that's the dead space. So you have two types of dead space. One is anatomical, which is the volume in the conducting airways, the conducting passages. It's about 150 mils. In a disease state, in a normal person, alveolar dead space is exceedingly small normally, very, very, very small. Okay, it's tiny. In fact, it should be approaching 0 because the alveolar space should be always available for gas exchange. But in a person with disease, you have some alveoli that have stopped being able to carry out gas exchange, for a variety of reasons. There's collapse or obstruction or no blood flow around those alveoli, so they're not involved in gas exchange, and therefore that is called alveolar dead space. But anything other than a tiny, tiny amount is abnormal and indicates some sort of disease if there is alveolar dead space. So total dead space is equal to anatomical and alveolar dead space. They are called physiologic dead space. Do not confuse dead space and residual volume. I think I can remove this. Wouldn't be bad to remove it, maybe. Okay. Let's move on. Oh, we already talked about tidal volume. On average, tidal volume is about 150. And dead space, in terms of anatomical dead space, is, tidal volume is 500, and anatomical dead space is 150. So dead space represents a fair amount of the tidal volume. You're sitting there at rest, breathing in and out 500 mils, but 150 of that, which is 30%, 150 mils of that volume is, after all, just sitting inside the conducting airways. Your trachea, your bronchioles, all the way down through the conducting airways till we get to the respiratory airways. I'm not sure if it's necessary to erase it, but well, we'll erase these. Okay, let's move on. So as I said, in order to evaluate, to measure respiratory function, we use a spirometer, and measurement of volumes is spirometry, which can help us distinguish between obstructive disease and restrictive disease. I wouldn't get too much into this. I wouldn't spend your time trying to memorize, reduction or increase. I think the main thing to understand is with obstructive pulmonary disease, you have an increased airway resistance. And the kind of diseases that are considered to be obstructive pulmonary disease include things like asthma, bronchitis, emphysema. Those are obstructive pulmonary diseases. Restrictive diseases reduce the total lung capacity due to structural or functional changes. So, pulmonary function tests involve spirometry. They're very commonly done. They have pulmonary function labs in hospitals where they're measuring respiratory, trying to determine respiratory function. Typically, when you're doing a pulmonary function test, you have to coach the person because they really need to be pushed to try and get in as much air and then get out as much air when you're measuring forced vital capacity. Remember, vital capacity is from the top of inspiratory respiratory volume, or IRV, to the bottom of expiratory respiratory volume, ERV. That's vital capacity. And if you're forcing as hard as you possibly can, then that's the forced vital capacity. And we did that in the lab, and I showed you those results. And then you look at, typically, you look at forced expiratory volume 1. There should be a 1 in here, I guess. Well, it's discussed here. That's okay. So forced expiratory volume is the amount that can be expelled or exhaled during that first second of forced vital capacity measurement. When you're trying to exhale as much as possible, you take in to the topmost you can, and then you exhale. Normally, FEV1, the amount that you can put out in the first second of breathing out from the top of IRV, will be all the way down, measuring all the way down to the bottom. But in the first second, it'll equal about 75 to 85% of the FVC volume. And we did this in the lab. I think the results that I gave you, the data I gave you, showed a 72% FEV1, which is, perfectly fine. It's okay. It's very close to the normal. So, if you're breathing, you're moving air in and out. And if we look at the overall alveolar ventilation rate, we're talking about, you have to take into consider the frequency of breathing, the breathing rate, so breaths per minute, and then the tidal volume minus the dead space. And in a normal person, the dead space, as I said before, should be about 150 mLs. Anatomical dead space is most of that total dead space. So TV minus dead space, average tidal volume is about 500, average dead space, anatomical dead space is about 150. So on average it would be about 350, and a normal person, I think it's 12 per minute. Is it 12? 20 per minute. No, yeah, 20 per minute normal respiratory rate, tidal volume, dead space. That means that the minute ventilation, the amount of air moving in and out of the lungs, in and out of the person's mouth, that is about 10 liters per minute. That's 500 mils times 20. That's minute ventilation. But the actual alveolar ventilation, you have to subtract dead space volume. So that's 7 liters per minute on average. Now, it's important to understand how dead space plays an important role in overall alveolar ventilation at different rates of breathing. If a person slows down their breathing and breathes slower but deeper, so that their tidal volume is doubled here, you see, 1,000 mils from the normal background tidal volume, or breathing at rest, they slow down their breathing, they breathe deeper and slower, so they double their tidal volume and they halve their respiratory rate. Then what you get is the exact same minute ventilation, how much total air is going in and out of their body, in their mouth. But the alveolar ventilation rises to 8.5 liters per minute. That's because 1,000 minus 150 is 850, times 10 is 8,500 mils. Okay, so the percent tidal volume when you are breathing slower and deeper is only 15%. The dead space doesn't contribute as much of volume to the actual space that's involved in gas exchange, total possible gas exchange. If a person starts to breathe rapidly and shallowly, which can happen at times, certainly, and at worst is hyperventilation. Then the dead space contributes a much bigger percentage because their tidal volume, if they're breathing a shallow, smaller tidal volume, shallow breathing means smaller tidal volume. If their breathing is halved and they double their respiratory rate, yes, they're still at that 10,000, the same as here and here, but the alveolar ventilation drops significantly. So breathing rapid and shallow is something that is not effective. Breathing fast and shallow is even worse. Faster and shallow is even worse because you're also breathing, with this kind of breathing, you tend to also start breathing off more CO2 and dropping your PCO2. And when you drop your PCO2, you in your blood, because you're blowing off more CO2, you'll tend to raise the pH and go out of the normal physiological pH range. You should keep these things in mind, the relationship between breathing and PCO2 and the relationship between PCO2 and pH. Okay, let's talk about disease processes, disease states. The number one respiratory disease in the world is asthma. That's the most common respiratory disorder, asthma. It is considered a chronic obstructive pulmonary disease. It involves increased airway resistance, more resistance to flow. It's more difficult for people with asthma to pull air in, particularly if they're having an attack. So characteristics include an intermittent, not permanent, but intermittent increase in airway resistance. Symptoms are reversible. It can be reversible spontaneously. It gets better at times. Sometimes it gets worse. Sometimes it gets better. There's always some kind of trigger. It is, in fact, an immune response to a particular trigger, foreign antigen molecule. But if a person is removed from that, they will improve. But another way of reversing the symptoms is through using a inhaler that contains a bronchodilator. In the end, however, with this kind of with asthma, you get a chronic inflammatory process going on in the airways. The immune response or hyperallergic response can cause that. Sometimes infections can cause asthmatic symptoms. Some people have cold-induced asthma. They're sensitive to cold. Some people have exercise-induced asthma. With exercise, particularly in cold, dry air, they'll start getting reduced airway resistance. What they're getting is bronchoconstriction. So there are certain foreign molecule triggers or certain stimuli that can trigger an increase in bronchoconstriction. There's an increase in smooth muscle contraction around the bronchioles. And if you use a bronchodilator that has epinephrine-like effects, it'll cause dilation, relaxation of that smooth muscle. Unfortunately, people who have an immune response to a particular antigen causing their asthma, they are allergic to some particular environmental stimulus or foreign antigen, they have not only an increase in airway smooth muscle contraction, but over time get an increase in the amount of smooth muscle around their airways, and so there's even more muscle, smooth muscle there, and they get progressively, with time, over time, more harder constriction, more bronchoconstriction. Pulmonary disease has been increasing steadily over the years. Now, part of this you have to understand is it's being studied more, and the ability to detect it has increased with time. This is the incidence in the population. Some cases of asthma spontaneously revert back to normal. People have childhood asthma, and then as they get into young adult years, then their asthma disappears. Others, it doesn't. The later you have onset of asthma, the worse it is usually, and the less easily it can be treated. But it is definitely increasing in prevalence, not just because it can be detected. They have more sensitive methods of detecting it, but also because there are increased there's an increased exposure to triggering stimuli. Not all of the increased incidence is actually clearly understood. So, asthma is a obstructive pulmonary disease. There are other pulmonary diseases that are obstructive. Chronic obstructive pulmonary disease, they include bronchitis and emphysema. Some people unfortunately have both. Again, an increase in airway resistance, narrower airways, sometimes blocked with mucus. Flow does not improve with the use of a bronchodilator as it does in asthma. In asthma it does, but in these COPD, chronic obstructive pulmonary diseases, it does not. And it is not due to an increase in smooth muscle contraction, which is why it doesn't respond to bronchodilators. In emphysema, you have a destruction of the airways, mainly loss of alveoli. You actually get tissue loss. In chronic bronchitis and inflammation in the bronchioles, you have excess mucus production. Often the mucus-producing cells increase in number, and you have a chronic inflammatory process going on. In these kind of diseases, emphysema or chronic bronchitis, the respiration ends prematurely. In other words, you're not breathing in quite as much, you're not breathing out quite as much. There's an increase in these, but I wouldn't worry too much about that. But one thing for certain is that FEV1 is decreased significantly in these kind of chronic obstructive pulmonary diseases. Remember that FEV1 is also reduced significantly with asthma, but responds dramatically to the use of a bronchodilator. There are some other kinds of pulmonary diseases that are considered restrictive. If you have increase in fibrosis in the lungs because of an accumulation of scar tissue, then you have fibrosis, and that's a restrictive type of disease. Pneumonia is pulmonary edema. These are restrictive kind of diseases. What they do is they significantly reduce lung compliance. The ease of expansion or compliance of the lungs is significantly reduced in these kind of restrictive pulmonary diseases. You have increased stiffness of the lungs and limit to the ability that they can expand, so lung compliance is significantly reduced. You have to generate more negative pressure to get an increase in volume. You have to work harder to increase the volume in your lungs to get a lower enough pressure so that you get enough a difference between the pressure in your lungs and the pressure outside, and that air flows in. So you have a limited ability in inspiration. FEV1 is increased because of the recoil of those stiff lungs. So you may not be able to breathe in as much when you measure the forced vital capacity. But when you breathe out, FEV1% goes up because the lungs are more stiff and collapse, the recoil's stronger. So you have stiff lungs increase FEV1. There are many different, anything where you are moving air in or out of your pulmonary system. Any of these are considered non-respiratory air movements. Okay, let's just talk a little bit about the larynx. The larynx includes the epiglottis, and when it's closed off, it changes dramatically what could happen. You can have a closed airway. You close your airway voluntarily, and then try and exhale against that closed airway, and that's what happens during coughing and sneezing and the Valsalva maneuver. I've talked to you before about the Valsalva maneuver. I explained it in association with the lab exam. That's a prolonged effort to exhale or breathe out against a closed airway. So air temporarily is held in the lower respiratory tract. That means below the epiglottis by closing off the epiglottis. Okay, so it's held in there, and then using increased abdominal pressure, contracting the abdominal muscles, person tries to breathe in against that closed airway. And people use this to help empty the rectum when forced defecation. They're holding their breath and pushing. It's actually not uncommon. That has an effect, by the way, on your heart, because you're pressing on your heart when you do that, and it reduces significantly venous return to the heart. Okay, you're breathing out against a closed airway. You're increasing significantly the intrapulmonary pressure. It presses in on the heart. The heart's in the pericardial cavity, and it presses in on the heart and restricts the ability of blood to return to the heart. So your venous return goes down, and with venous return going down, you have a decrease in end diastolic volume. So you have a decrease in stroke volume, and with a decrease in stroke volume, of course, you have a decrease in cardiac output, and with a decrease in cardiac output, you have a decrease in blood pressure. So the Valsalva maneuver will cause a decrease in blood pressure, and those people sometimes faint or have a heart attack if they have a severe heart condition. It can trigger some pretty bad things. Certainly, it makes you dizzy if you do a prolonged Valsalva maneuver. So again, these are just, some happy descriptions all through here, but let's move on. Okay, now the rest of this, I'm pretty certain the rest of this lab is is actually a repeat and a review again to make sure that you understand some of the aspects that are occurring in terms of gas exchange. Okay, we did cover gas exchange when we did the cardiovascular system. We did blood, and we're going to do it again to drive that home because it's so key and so important in terms of overall physiological function. And so the relationship, particularly, all the systems have interactions, but particularly the respiratory and cardiovascular systems have a lot of important interaction with each other, and we're going to review that.